Ours is working. Okay. For now.
Months of effort, critical thinking, and collaboration, and we appreciate your presence as an audience and your engagement during the sessions. Before we begin, just a quick reminder about the presentation format. Each student will have 12 minutes to present, followed by 3 minutes for questions and answers. Please hold your questions until the Q&A portion, and be mindful of time so we can stay in schedule. So for the speakers, Dr. Suluri is going to take the time, and when it's already 10 minutes past, you have 2 minutes to go, she's going to give you 2 fingers reminder, okay? And then we'll have 3 minutes for Q&A, and we'll stick to that. So once we only have 30 seconds left with like the last question. Sorry, you have to go with that, okay? So, thank you again for joining us today. Let's get started with our first presenter. She's majoring in biology with a concentration in veterinary medicine. She is from Haines City, Florida, and has been at SEU for 2 years. While at SEU, she has served as a biology TA, chemistry research student, a Christian Veterinary Fellowship Club member, or CVF. She also is CVF Tampa Urban Outreach volunteer, a mission trip member to Ireland last year, and volunteered to care for animals at Dirt Road Farm. After graduation, she plans to attend veterinary school to obtain her doctorate in veterinary medicine. Let's all welcome Ms. Mia Alano Acosta.
Good morning, everybody. My name is Mia Alano Acosta, and my capstone today is on linking-induced early alpha-synuclein-related cellular stress in the gut microbiome of Parkinson's disease, specifically in macaque monkeys. So Parkinson's disease affects around 2% of people in the United States over the age of 65 and about 10 million people worldwide. So this disease has been on an uprise both on a global and national scale, with the Parkinson's Foundation predicting that within the next 25 years, that 10 million cases of Parkinson's will double. So this is quite a prolific and substantial disease, as Parkinson's is a progressive neurodegenerative disorder that impairs motor function. So as the patient ages, they will experience more severe and harder to manage symptoms. So Parkinson's, the etiology is unknown, but it is characterized as a loss of dopamine neurons within the substantia nigra. And that is the portion of our brain that controls things such as our movement, as well as produces our dopamine neurons. And the point at which a patient is diagnosed with Parkinson's, they have already experienced a loss of 50 to 70% of the dopamine neurons within their substantia nigra, which is of course a very substantial amount, as this is completely irreversible. There is no known cure for Parkinson's. There is only treatments that will help alleviate some of those outward manifestations that we see in patients typically. So Parkinson's, the loss of dopamine is caused by the buildup of a toxic metabolite known as dopal. So dopamine is converted into dopal in a patient with Parkinson's disease, and it is not being converted into the non-toxic form. So we're seeing an accumulation of this molecule right here, which is toxic to dopamine. And since dopamine is a neurotransmitter that's involved in regulating our movement, when we see a loss of dopamine, we're seeing an impairment of movement and overall loss of motor control.
So annoying. Yes.
And something that has been of recent research with Parkinson's and its correlation to dopal and the outwardly symptoms that we see is this protein alpha-synuclein. So alpha-synuclein is a protein that is part of the regulation of the release of neurotransmitters, specifically with dopamine. But in patients with Parkinson's disease, this protein is misfolding and it's mutated. And the misfolded form will aggregate into these oligomeric forms. And these oligomers then will insert themselves onto the membrane of synaptic vessels, creating a pore-like channel that dopamine is able to then leak out of. That dopamine is being converted into the toxic form, and that's when we're seeing those outwardly symptoms. And alpha-synuclein has also been linked to the gut microbiome. It is in its highest density in the muscularis externa, which is the third layer of our gut. And patients that have had Parkinson's disease, post-mortem autopsies have shown that they have similar alterations in their gut microbiome. Specifically, we see increased levels of the phylum Actinobacteria and Verrucomicrobia, and a decreased levels of microbes within the phylum Bacteroidota and Firmicutes. So the belief is that this dysbiosis within the gut microbiome will cause the alpha-synuclein protein 2 mutates, which then it will travel up through the vagus nerve and cause those issues that we had mentioned previously. And since alpha-synuclein aggregation precedes the aggregation of dopal, it is associated with the prodromal symptoms of Parkinson's disease. Prodromal symptoms are the symptoms which precede the outwardly motor symptoms that we so commonly associate with our diseases. And the prodromal symptoms for Parkinson's are anxiety, depression, sleeping disorders, but most specifically, constipation seems to be the biggest one. And then we see the motor symptoms, slowing of movement, posture instability, tremors, and just an overall loss of motor control. But at the point at which these motor symptoms are being experienced, there has already been a significant loss of dopamine neurons well underway, which we did talk about that being completely irreversible. So something of special interest to me in this topic is that in 2021, there was the first case of a naturally occurring non-human primate with Parkinson's disease. So this occurred in a cynomolgus macaque monkey, and here he is. As you can see, he has that characteristic tremor that is so commonly seen in patients of Parkinson's, as well as just an overall slowing of movement. But he didn't just exhibit these outward symptoms, he did also have a substantial decrease in dopamine neurons within his brain, which is the primary indicator of Parkinson's. So we know now that Parkinson's is not a uniquely human disease, but is starting to affect our animals as well. Which leads us into our general objective for the capstone, which is to determine measurable prodromal behaviors that precede the substantial loss of dopamine neurons within our brain that is caused by early cellular stress response caused through the alpha-synuclein mutations in macaque monkeys. So our first specific aim seeks to examine the behavioral regression of prodromal behaviors, primarily constipation on macaque monkeys of Parkinson's disease, through analyzing their stool frequency as well as the quality of their stool. And our null hypothesis for this is that there will be no significant difference in the prodromal behavior or quality of stool between our experimental and positive and negative control groups. So for this experiment, we will establish 3 different groups, that being a positive control, a negative control, and an experimental group. So our experimental group will be induced with that mutated alpha-synuclein form. Our positive control group will be induced with a normal alpha-synuclein form, and our negative control will just be a healthy group of macaque monkeys with no prior illnesses. Each group will contain about 28 male macaques around 5 to 8 years old, which puts them in the young adult to adult age range. And all monkeys will be taken care of in the same manner to avoid any biases, given ample time to adjust to their environment before the procedure actually takes place. And for our first specific aim, we need to induce our experimental and positive control groups with this alpha-synuclein. So our experimental control group will be receiving an inoculation of the preformed alpha-synuclein fibrils that are about 50 nanometers in length. This will be done via direct injection into the muscularis externa, which was that layer of the stomach where they aggregate most frequently. And we will also be obtaining fecal samples over the course of 9 months, with destructive sampling taking place 4 times over those 9 months, once at 1 month, 3, 6, and then finally at 9, and 7 monkeys will be destroyed during each of those 4 samples. And bowel movement will also be monitored in its frequency during that time as well. So to analyze our fecal matter, we first have to homogenize the mixture, which will just allow us to improve the detection and reproducibility of it. And we can then extract the bacterial DNA out of the fecal matter. For this, I'll be using the DNA extraction power fecal DNA isolation kit, which is just a simplified way of doing what we need to do. And then we can analyze the relative abundance of the phyla within our sample using a 16S RNA sequencing. Specifically, we'll be looking at the V3, V4 region, which this region is what will identify and differentiate our phyla from each other. So they will be different in that respect. And here is a sample of some graphs that we expect to see with the data we collect. So these are 2 graphs with just 1 sampling of data, but over time, we do expect to see a decrease in the bowel frequency of our experimental group, which is indicated by that yellow line, and our control both positive and negative, we do not expect to see very much changes in their bowel movement frequency. And this will also correlate with the bacteria phyla. Specifically, this one I just pulled Firmicutes, but we were also looking at the other three as well. And we also expect to see a decrease in the relative abundance of this phyla within the fecal sample of our monkeys. So we expect that there will be a decrease in bowel frequency as the gut microbiome continuously alters and continuously progresses. So our null hypothesis is not supported for this first specific aim, which leads us to our second specific aim, in which we aim to identify early cellular stress markers that correlate with the prodromal defects seen, that being constipation, within the gut microbiome of the alpha-synuclein exposed macaque monkeys. And our null hypothesis as for this as well is there will be no significant difference in those that were induced with the experimental group and those that were not induced with the alpha-synuclein. So for our specific aim 2, we will be utilizing the same macaque transgenic monkeys that we obtain in specific aim 1, as these extractions will be done simultaneously. And we'll be targeting the muscularis external layer, of course, where we will be taking a thin layer of tissue, and then we'll be able to filter and plate that tissue. And for this specific aim, we'll be monitoring mitochondrial stress. So that will be done through using a JC1 dye, where after the incubation, we will immediately image the cells, and any cells that appear green will be indicated as stress mitochondria, and the red cells are healthy mitochondria. And this is a sample graph as well of what one sample would look like. But then after over time, we expect to see a decrease in the ratio between red and green mitochondria. So that means with the fluorescence that there was an increase in the stress mitochondria within the cells of the macaque monkey. And so as the progression of the mitochondria markers, they will correlate with the progression of the non-motor symptoms that we saw within specific aim 1, specifically that being constipation, as well as the increase or decrease of the bacteria phyla observed in specific aim 1 as well. And on the left there is an example of what our imaging will look like under the different filters. So our conclusion for this, our capstone is that prodromal effects may serve as a potential biomarker for early screenings of Parkinson's disease. Which could lead to earlier treatment plans as well. And it can serve as a non-invasive form of sampling for PD, as usually patients that are experiencing this are older in age. So we may be able to obtain a diagnosis before a severe loss of dopamine neurons is experienced. And our future studies, we want to repeat the procedure utilizing female macaque monkeys, and as well as treatments that can target the alpha-synuclein aggregation. And I finally like to acknowledge my family and my friends for their love and support, Dr. Horton for my advisor on this capstone, and Dr. Salvatore, who I served under my research as well. The researchers who contributed all of their findings and knowledge that allowed me to put this capstone together, and as well my ultimate gratitude and love towards God for all of his support that he's shown us as well, and my references. And then any questions?
All right. Now, question and answer portions open for everybody. Any questions?
I have one.
Okay, Dr. Salute.
Mia, when you were doing the research, how long beforehand did the patients exhibit the prodromal signs before the motor signs?
Yeah, so that's what's interesting about it, is that it did vary between patients and patients, because it is something that you wouldn't initially pick up on. Like, not a lot of people initially think, oh, my anxiety is linked to Parkinson's, if that makes sense. So it varied between 3 to 6-ish years was the literature that I was reading. But since that is harder to detect and to link with Parkinson's, there was that variation there between patients.
Right, which would lead to a difficulty in treating it before it actually presents, right?
Yes.
And what was the percentage of people that had those microbes? You said is it all of them that had it, or was it?
Yes, so in the study that was done, there were 10 post-mortem autopsies done, and all of the individuals that were within that individual study did see those increased levels of phyla or a decreased level in those certain bacteria.
Was that the only study that was done with that?
That was the only one that I saw, yes.
Any other questions? Yes.
So you talked about the positive and negative controls, and I guess my question is, what's the difference between inducing alpha-synuclein protein and not doing so? Because they already have a corrected alpha-synuclein protein, correct?
Yes, so for that, we wanted to establish a positive control where we could induce that normal alpha-synuclein so that the body is being induced with a foreign substance. So when we did our experimental group, our data collected wasn't just because it was induced with a foreign substance. So we wanted to have that comparison and then have a group as well that wasn't induced with anything.
Gotcha. And then for the constipation, is that just a prodromal symptom that is easiest to research with, or like why would you choose constipation over the other prodromal?
Yes, that one is by far the easiest to research because anxiety and depression is one of those things that does vary between individuals, and what is considered anxiety and depression within oneself might vary as well. But something that we can analyze scientifically, microscopically, would be the fecal samples through the constipation. Yes, thank you.
Any other questions? I got a question. So, yes, go ahead, go ahead. Go ahead, yeah. I thought there was something.
When I was doing the research, were there any other mammalian species that suffered with Parkinson's disease that maybe in the future you wanted to investigate?
Yeah, so that is also very interesting as well. Before I get to that, there was actually just in this January of 2026, another macaque monkey was found to have naturally occurring Parkinson's disease. But another mammalian that you asked about was actually the tree shrew, which is quite interesting because they are not as similar as humans in regards to the monkeys. So,
Great, thank you, Mia.
Okay, we're running out of time.
Well, our next presentation is Jacqueline Zelapesca. She's majoring in biology with a concentration in med sciences and minoring in chemistry with neuroscience. She's from New Jersey and has been at SCU, so that's why, is that why I got to pronounce her? Maybe. Has been at SCU for 4 years. While she's here, she's been the volunteer coordinator at the SCU Health Clinic, a side peer mentor, a social media chair for Flora, a club member of SCMPA, which is the student chapter of the Medical Dental Association, PHSO, which is our honor society, and the American Chemical Society. Upon graduation, she plans to pursue a master's degree during her gap year while applying to med school and continuing gaining clinical education and experience to further develop her patient care skills. Go for it, Jack.
Hi everyone, my name is Jackie, and today I'm going to be presenting my senior capstone on the investigation of anti-inflammatory and neuroprotective effects of microgreen-derived sulforaphane and a mouse model of neuromyelitis optica spectrum disorder. So the importance to this is that neuromyelitis optica is interchangeably known as NMO, and it's an autoimmune disease that affects the central nervous system, and the importance of this is that autoimmune diseases affect roughly 8% of the US population. Although they're kind of rare, they're often chronic and debilitating. So over here I have an image of autoimmune diseases and common areas they can affect in the body. So starting from the top, we have inflammation that occurs in the brain, such as multiple sclerosis and also NMO. We have attacks against the thyroid, such as Hashimoto's, the skin, such as psoriasis and eczema, the GI tract like celiac, ulcerative colitis, and Crohn's disease, as well as effects in the joints, such as rheumatoid arthritis. Basically, what happens in an autoimmune disease is that the body makes antibodies to attack healthy tissue, causing chronic inflammation. And so the disease we're going to be talking about today is NMO, and here are the highlighted areas of inflammation that are affected in this disorder. So there is unfortunately no cure to any autoimmune disease, and that's why I decided to do my research on this. So what exactly is NMO? NMO is an autoimmune disease that targets the central nervous system, primarily the optic nerves and the spinal cord. It's a mediated attack that attacks the astrocytes in the central nervous system, consequently leading to inflammation, demyelination, as well as neurodegeneration. And this disease actually used to commonly be mistaken for multiple sclerosis, but it wasn't until 2004 till they discovered the antibody specific to this disease called aquaporin 4 antibody, which is what attacks these astrocytes in the central nervous system. So the disease mechanism is that once this aquaporin 4 autoantibody is released, it's going to bind to the aquaporins in the blood-brain barrier right here. So here's a blood vessel and here's the brain. These are the astrocytes with healthy aquaporins, completely intact, impermeable blood-brain barrier unless something is able to pass through. And here is a damaged blood-brain barrier from NMO, and we have the antibodies attacking those aquaporins, leading to the discoloration to mimic damage to the astrocytes and chronic inflammation. So it's commonly seen that inflammatory cytokines such as interleukin-6 and interleukin-17 are risen, and then anti-inflammatory cytokines often decrease with this disease. So again, it also leads to neuroinflammation and secondary demyelination. Secondary demyelination means this disease doesn't target the myelin sheaths on the neurons, but rather it targets the astrocytes, and once those are damaged, the myelin sheaths are also damaged. So here is a visual of a healthy blood-brain barrier. We have these as astrocytes. These are specifically the blood processes of astrocytes that are what keeps that blood-brain barrier intact. And on over here, I have a healthy neuron with healthy glial cells. Glial cells are what's used to protect these neurons in our nervous system, because once the neurons are damaged, they don't really have really good ability of regeneration. So these glial cells work really hard to keep our neurons intact. And here is a damaged blood-brain barrier from NMO. So we see the blood processes, they are damaged. It leads to a more permeable blood-brain barrier, which is what the neurodegeneration and chronic inflammation is caused by. And here is a demyelinating neuron on the left. Okay, so some symptoms of this disease is chronic fatigue, vertigo, myelitis, which is inflammation of the spinal cord, muscle weakness, optic neuritis, and vision loss. These symptoms vary on case-to-case basis, but the difference in this disease is that the onset is really acute. So someone could experience vision loss really suddenly, and it could be classified as either monophasic or relapsing disease. So someone could get an immune attack just once, and it would kind of subside after that, but most people have relapsing forms, so they never really know once they're going to have an episode. So some current treatment options are to manage the symptoms of this disease rather than cure it. So the main goal is to reduce inflammation and lessen the progression of the disease. The most effective treatment on the market are called biologics, and these work by prohibiting certain pathways that inflammatory cytokines usually travel through. So it will block, such as interleukin-6 block, but there are some downsides to these treatments, such as they're really expensive. They're like $10,000 to $30,000 a year. And they also still have risk of increased infections. Bringing me to my next point, immunosuppressants. These are used to just keep the immune system at bay, help keep it from overreacting, but there are still risks to that, as well as an increased infection rate. There are also injections such as steroids or immunoglobulins, but these are used once an episode occurs, so it's not going to prevent it from occurring, it would just treat it. As well as physical therapy to help slow the progression of the disease. So why did I choose sulforaphane? Sulforaphane is a really potent compound found in broccoli microgreens. Microgreens are known to have a lot of beneficial effects to the human body, and there have been multiple studies showing their effects on pro-inflammatory and anti-inflammatory cytokines. Some being that they can suppress pro-inflammatory cytokines, promote anti-inflammatory cytokines, as well as activate the NRF2 pathway, thus leading to antioxidant effects. It can also cross the blood-brain barrier once it's absorbed. So the research gap is that research does indicate the really potent anti-inflammatory and neuroprotective effects of sulforaphane. There has also been successful research in treating experimental autoimmune encephalomyelitis mouse models with sulforaphane, in reducing inflammation by prohibiting the pro-inflammatory cytokines and activating the NRF2 pathway. And the gap here is that there is limited research on NMO mouse models, and there is no research exhibiting the effects of sulforaphane on NMO mouse models specifically. So I'm going to preface by saying I'm using the same mouse model for both AIM-1 and 2, and I'm going to grow the microgreens locally and extract them in the lab. I'll be using C57BL6 mice, and the mice will be at 9 weeks of age because they'll have a stabilized immune system. And I'm going to be using 30 mice, so 10 mice in each group. So group 1 is going to be induced with NMO, treated with sulforaphane with an injection. Group 2 will be induced with NMO and treated with sulforaphane in gavage. And then group 3 will be my control, so it'll just be an NMO mouse model. So here's my experimental timeline. On day 0, I'm going to inject all of the mice with the aquaporin 4 peptide as well as an adjuvant to stimulate the immune system. Day 7, we'll have a booster shot to make sure the mice is successfully induced with NMO. By day 14, there should be a peak immune response, so the mice will all have NMO. And then on day 14 to 30, each day I will be treating groups 1 and 2 with sulforaphane, either via injection or gavage. And then finally, in step 4, for AIM-1, I'm going to extract the blood sample, and for AIM-2, I'm going to extract the spinal tissue. Okay, my specific AIM-1 is to investigate the anti-inflammatory effects of sulforaphane in mouse models of neuromyelitis optica. My hypothesis is that the administration of sulforaphane will promote anti-inflammatory effects by decreasing the levels of interleukin-6 and aquaporin 4 antibody, as well as increasing the levels of anti-inflammatory cytokines, interleukin 4 and interleukin 10. So my null hypothesis is that administration of sulforaphane will have no significant difference in these circlones. So AIM-1. So on day 30, I'm going to be taking a blood sample from each mouse. The blood sample will be centrifuged and the serum will be taken. I'm going to perform an ELISA assay on each sample model, testing for the pro-inflammatory signs such as the aquaporin 4 antibody, interleukin 6, and then the anti-inflammatory cytokines, aquaporin 4 and aquaporin 10. Okay, so my expected outcomes is that mice treated with sulforaphane will have an increase in anti-inflammatory cytokines, as well as a decrease in pro-inflammatory cytokines. And my control line will have an increase in pro-inflammatory cytokines and a decrease in anti-inflammatory cytokines. So my specific AIM-2 is to investigate the neuroprotective effects of sulforaphane on an NMO model. My hypothesis is that the administration of sulforaphane will promote a potent neuroprotective effect by the upregulation of the NRF2 expression in these mice, thus increasing the antioxidant activity and reduce neurodegeneration of the control group. And my null hypothesis is that the administration of sulforaphane will have no effect on the NRF2 expression. So here's how I'm going to carry it out. On day 30, once the blood sample has been taken for specific AIM-1, I'm going to go ahead and euthanize the mice in a humane procedure. I'm going to use the spinal tissue and homogenize the spinal tissue. It'll be then centrifuged and the protein liquid will be extracted, and a Western blot will be performed to measure the concentration of the NRF2 protein. So my expected outcomes is that the control group will have a decrease in NRF2 protein, thus increase in oxidative stress, and my mouse group treated with sulforaphane will have an increase of NR2 protein, thus a decrease in oxidative stress. So future studies, I hope that if this study is successful, we can evaluate the anti-inflammatory effects of sulforaphane in use of humans with NMO, as well as integrating sulforaphane in combination with other drug therapies, and promoting a dietary therapy to integrate into those affected with autoimmune diseases to reduce inflammation, oxidative stress, and tissue damage. My acknowledgements are God, family and friends, Dr. Strong, my advisor, and my professors.
Okay, so open to questions?
Yes.
So, have there been models made for just like NMO mice before, or is that something new as well?
Yes, there have been models of animal mice, there just haven't been models using sulforaphane in treatment with those mice.
Gotcha. And is there a reason you picked 10 mice per group?
Yes, because the mice are already genetically modified, so we don't necessarily need big groups of these mice because they're all kind of gonna act the same. So I only chose 10 for each group.
Thank you.
Any other questions?
So going to the NMO, what it does to the brain, you said it damages the astrocytes. What exactly is it damaging in the astrocytes? Because you said that damage leads to minor damage.
Right, so once that antibody alpha-4 or any antibody binds to alpha-4s on the processes of astrocytes, it leads to more permeability in the blood-brain barrier. So it leads to damage to the astrocytes, and they will no longer be able to protect the brain like they should.
Gotcha. And then back to the other question about the sulforaphane treatment, how is it different from other treatments that are already out, if there are other treatments that are?
Yeah, so sulforaphane the reason I chose it is because if it works properly, it would provide more of a holistic approach to mitigating autoimmune diseases. The treatments we have right now are like biologics, immunosuppressants and all that I've said before, but there haven't been many human studies using natural therapies such as sulforaphane.
I have a question. So, you're extracting your own sulforaphane,
Yes.
right? So what is the solvent and how are you gonna extract it?
Yes, so I'm gonna grow the microgreens locally. We're going to wait until day 10, harvest them, and then homogenize them as well as hydrolyze them for about 3 hours in a water bath. And then they'll be carried through the liquid extraction with dichloromethane, and the organic portions will be taken. And then they'll be run through silica gel, solid phase extraction with dichloromethane, ethyl acetate to wash it, and then dichloromethane.
So why DCM? Why are you using that solvent?
Because previous studies that I've seen with extraction of sulforaphane have used that solvent and it has been successful, so I believe that would.
You know how much yield you're gonna get, you think?
I've seen studies with about 97% yield, but
Per gram, per?
no, like 50 grams, or yes, 50 grams of microgreens.
50 grams and you get 90%. Wow.
Do you know what concentration of sulforaphane you need to use in?
Yeah, the mice will be treated with 75 milligrams per kilogram, and then that portion of sulforaphane will be placed in a phosphate buffer solution.
All right, that's our last question. Thank you, Jennifer. Dr. Sulu, are you supposed to introduce Kaya?
No, but I will. No, but I
Who's your
will.
advisor? Yeah,
Oh, I guess-
you're the one.
Oh, I guess it's.
Yeah, that's yours.
I would gladly introduce Kyra's majoring in biology with a concentration in medical sciences and monitoring in humanitarian compassion and chemistry. She's from Jacksonville, Florida, and has been at SU all 4 years. While at SU, she served as an A&P and physics TA, Orgo Chem Research student, medical missions trip member of the School of Honors, PHSO, SCMPA, Alpha Chi, and Psi Peer. We don't have time for her whole CV because it would be extensive. After graduation, she plans to go to medical school in May, and in May work at the hospital as patient care tech through the summer.
Good morning. Today Today I will be talking about my capstone, Predicting the Unpredictable, a proposed AI model for sickle cell vaso-occlusive crisis. Okay. So my PowerPoint's not working, so I'll just do it off the cuff. And so what is vaso-occlusive crisis and what is sickle cell? Sickle cell disease is the most common inherited blood disorder in the world. About 3 to 7 million people have it. It's predominantly people in sub-Saharan Africa and Middle Eastern descent. Maybe we'll get it. Okay. The disease is caused by a recessive gene mutation on hemoglobin S, which causes the erythrocytes to take on a sickle shape. So our sickle cells, are biconcave discs, and they're also carrying oxygen. But those with sickle cell, they actually, like the name says, sickle, and they don't carry oxygen very well. And as we know, structure dictates function. And so when we alter the function, when we alter the structure, we alter the function. And so we've actually only done one substitution, which is glutamate for valine. And so glutamate is a negatively charged amino acid, and valine is nonpolar and it's not normally there, and so that's what's causing most of the problems. There is a cure for sickle cell disease, but the problem with that is that it's $2 million, and so for the 100,000 patients in the United States, that is not covered with insurance, and most people can't afford it. And again, most patients are actually not applicable for it because of the severity of their disease. So what is the problem with sickle cell? So these patients are chronically anemic, and they also have these issues in the microvasculature because of the sickle shape. They actually don't pass through the microvasculature, so like the capillaries, and they can have swelling in a lot of these areas. You can see red blood cells, white blood cells, activated platelets. These are all players in the vaso-occlusive crisis. And so 250,000 hospital admissions are related in the United States are related to a VOC, and 95% of those are related to a VOC. And so patients, when they come to the ER, their average pain rating is 9 out of 10, and that's the average. And so we have sickle cell patients experiencing a VOC. Most of them are admitted about 7 to 10 days, maybe 11, depending on the severity, with a 40% readmission rate. And so you can see how devastating this disease is on your relationship, on your finances, on everything. So what is the clinical gap that I'm trying to solve? VOCs are unpredictable. The average patient has them about 3 to 8 times a year. And so this is devastating, especially if you're readmitted 40% of the time. They're devastating. They can have a lengthy amount of time from treatment to onset. We actually recommend treatment from onset of symptoms to the end to be about 60 minutes. But if you've ever been to the ER, have you ever been seen in 60 minutes? That's not really the case. Predictive technology may allow for faster treatment, less organ damage, and better patient outcomes. Blood biomarkers have been researched in the literature to have possible predictive ability. I'm looking at the prodromal phase, and so that's like the leading up causes, the days, about 72 hours before a crisis. So my research question is, can longitudinal biomarkers and CBC complete blood counts predict the onset of vaso-occlusive crisis in patients with sickle cell disease, HBSS, which just means homozygous for the disease? And so my hypothesis is that gated recurrent units, GRUs trained on longitudinal CBC data, will enable meaningful predictions of VOCs in hemoglobin SS patients. And my null hypothesis is, of course, they will not yield meaningful predictions of impending VOCs. So gated recurrent units, where are we in AI sphere? There's so many words that are being thrown at you in AI, and so I'm going to break it down a little bit. So artificial intelligence is like your Siri. It's like when you're typing and it's doing autocorrect, that's kind of like the general automated form. And then machine learning, the best way I can explain it is when your Netflix is recommending you the next show, because it's actually learning from you. It's learning from what you watch and learning from what you're going to watch and what you might like. And so then we're going to go one layer deeper into deep learning. And so that is what a gated recurrent unit is. It's an AI that is basically taking time series data, and it's taking that data and it's learning from it. It does mathematical functions, so you assign it weights, and then it's going to give you an outcome. So our input is going to be the CBC features over time. Our update gate is going to be how much memory to retain. Our reset gate, so we're going to be able to kind of forget the information that is not critical anymore, and that's really important in the temporal data because there is so much information that we're going to get from the CBCs that we're going to just have an overwhelming amount of data, and a human could not do that in the amount of time that we want to do. And then the candidate state is the proposed new memory, and then the hidden state, that's where you're going to assign weights and mathematical functions to each biomarker. And then we're going to have an output between 0 and 1 predicting the VOCs. My specific aim one is to characterize longitudinal CBC trajectories preceding VOCs in the HPSS patients using the sickle cell disease implementation consortium dataset. And so I chose that dataset because it's about 2,400 patients, it's in the United States, and it's geographically all around the United States. So you're not kind of honing in on just one ethnic group, like in Sub-Saharan Africa or in another country. And then my specific aim too is to develop and validate a GRU-based binary classifier to predict vaso-occlusive crises in the onset from longitudinal CBC time series data in hemoglobin SS patients. So this is just an example of a complete blood count. The literature suggests that with all the information, all the analysis and everything that sickle cell patient is experiencing, we can find time-dependent fluctuations in hemoglobin, fetal hemoglobin, red blood cells, platelets, reticulocytes. They're all going to be predicted. We already use some of these counts, like if someone has a really high white blood cell count, we're already predicting that they're going to have a hard recovery. And so I just wanted to show a little bit of the difference between unit control, so you and I, and then someone who's anemic or sickle cell anemia, that's also a name for it. Those with sickle cell anemia, it's really interesting. Our red blood cells last about 90 days, where theirs only lasts about 9 days. So my criteria for AHR extraction or electronic health record extraction, so we're going to have a confirmed HPSS genotype. And so we wanted to do that because each genotype is going to have a different amount of hemoglobin S. So that's really important that we keep it consistent. We're going to only include the patients enrolled in our data set, and then we're going to have a minimum of 2 CBC measurements. At least 1 documented VOC will be required for the log. And then for our exclusion criteria, we're going to have other genotypes are going to be excluded. And then we're going to have patients with less than two CBC data sets, because if we don't have more than 2, then we would not have any availability for time series modeling. Patients with bone marrow transplants or bone marrow malignancies or cancers, they would be excluded because they would have altered bone marrow function. And then patients with VOC data but no steady state data, they would be ineligible for this experiment because each patient is acting as its own negative control, which is very unique because there hasn't been a study like this yet in the literature that I've seen, because most of the CBCs that they're comparing them to you and I are not the same as someone with sickle cell, and they also don't separate the budget ahead. So I think that was a really big difference. So my methods for aim 1. So we're basically trying to just understand what is going on in the body. Our body sends signals, and we want to understand those signals. So we're going to take our data set, de-identify data. We're going to take the CBC time series per patient, and we're going to give them a random number, and then we're going to organize them chronologically, and we're going to do Z-score normalization. And the reason we do this is because platelets are counted differently than how we count hemoglobin. So if you tell the GRU, we have 10,000 platelets, and we have a hemoglobin of 8. It's going to think that platelets are way more important than hemoglobin, and that is not the case. We're going to have a sliding window segmentation. So every 72 hours might be a segmentation. That's when I'm proposing when we could predict a VOC. And then we're going to label those windows in possible admissions. So that would be a 1. They're having a confirmed diagnosis of a VOC, which is only diagnosed by a physician. There's no laboratory test for it, which makes treatment really hard because you can't treat something unless you diagnose it. And then we're going to have other windows. So when they're having their clinic visits, I remember when my brother was a baby, we were always at Wilson's Hospital getting those CBCs done to check his function. And so then we're going to have those non-crisis trajectories, and then we're going to put it in a 3D input tensor. That's just something that the GRU can read. And then we're going to go to the GRU model training, which is more my aim 2. And so when we train it, we're only training on 80% of the data set. We're estimating about 2,400 patients from the SCDIC. And the reason why you keep only 80% for training is that it's going to learn from that 80%, and then from that 10%, you're going to actually get your statistical analysis. And so we're going to train it and build it in PyTorch. We're gonna use back propagation, so that's when the GRU makes a prediction. So it gets all the CPCs from the following time series, and then it's gonna make a prediction. And then the prediction is going to be, yes, it's gonna have a VOC, or no, it's not gonna have a VOC. And then if it was wrong, it's gonna go back and check why it was wrong. It's gonna adjust the weight. So maybe we prioritized reticulocyte count more. Maybe we did not prioritize hemoglobin enough. And then, so then we're gonna go, and then after the validation set, we're gonna do the test set, and that's the last part. So predictions above 0.5 will be classified as pre-VOC, and those below 0.5 will be classified as steady state. We're gonna have a hidden state, that's just where all the math comes in, where you adjust the weights. And then we're gonna have a linear feed-forward layer, so you're only gonna get one number after all of these numbers, and it's gonna be 0.5, 0 to 1, and there'll be sigmoidal output. And then we're gonna test from the validation and testing, so we're gonna test accuracy, precision, F1 score, and area under the curve. Accuracy is true positives over total number of cases. Precision is total positives over predicted values. Your F1 score is balancing precision and accuracy, and so that is really important. And then area under the curve is separating your VOCs from non-VOCs, so you want to be able to do that. But again, this will allow us to compare it to other models, because there are other models that are trying to predict VOCs and other rates. So potential impact. So what potential impact does this have? Nothing yet, because we have to check all of the accuracies of the GRU analysis, and then we have to do prospective validation with real patients, real cohort, and external site and IRB approval. But before that, we would also have to include other things such as vitals, biomarkers. I would love to put a CMP, which is a complete metabolic panel. So you would have like lactate dehydrogenase, which is a big driver of inflammation. But you wouldn't have that in a lot of these cases, especially steady state, because doctors especially, they don't order a bunch of random tests. So this is retrospective data only. And then other models could be explored. The GRU is not the only one. I picked the GRU because they're actually using it to predict stroke and heart attacks and mortality. And so that's really interesting. And then other factors such as environmental factors such as like your temperature, your hydration, your exercise, and also altitude really affects people with sickle cell. And then you would do clinical trials, and then it would be amazing if you could see an EPIC and really get to know just a patient's risk and to inform them. Acknowledgements, of course, God, and then Southeastern University, and my advisor, Dr. Shaw, my husband Noah, and family and friends. Here are my references, and I'll take any questions.
All ready for questions? Any questions?
Look, I think I'm so far.
Okay,
I'm
we have a
well, like, wow, I really feel like,
Alright,
wow.
so, for your Z-score, how is that normalized exactly?
So we would normalize it, and we would do I would just really consult a biostatistician because I wanted to get it right. Yeah, I would consult a biostatistician.
Okay. Your selection of your patients, I didn't see that the heterozygotes are excluded or not. Are they included? The heterozygotes for sickle cell?
Like
The heterozygotes.
Oh, heterozygous, yes, we would exclude them because HBSS is the most common, it's about 65% of the.
But they were not listed, right? And they
Just
excluded.
HBSS, that is the homozygous. And I think I had SC, which is what my brother has, as excluded, because all other genotypes are gonna have different amounts of sickle cells.
So you excluded that heterozygote. Any other questions? Yes.
With that, then are you saying the heterozygous cells have less sickle cells?
Yes, yes, this is the most severe, and yeah, that's why I picked it, because they also have the most number of crises, so we want the most number of events, and I think that if you work backwards from the most severe to the least severe, I think that would be a good way to do it, but I think every single genotype will be different. That's the problem with sickle cell, that's why no one's done it yet.
Is that what you referred to with true positive was the?
No, true positive is the statistical analysis of whether we're able to catch every VOC.
So that's like sensitivity test, essentially?
So the whole point is to find a biomarker for like the patient before they have a VOC, right? So say all of this works, what would intervention for that patient look like?
So the intervention would be number 1, pain relief, and number 2, hydroxyurea, which is the only FDA approved one right now. There's other ones, but the purpose of hydroxyurea is to increase fetal hemoglobin, which kind of is like multiplying out the bad hemoglobin, and the fetal hemoglobin doesn't sickle like the way there's this.
What would pain relief look like? Like, what would be administered?
It's typically opioids. For instance.
Last question.
So, you opted for validation 10% out of your 80%. How do you, what's the criteria?
So that's typical of all DRUs.
Why? Why only 10%?
Only 10%. That's just what they do. And I consulted AI and AI.
Let's not trust AI all the time. But yeah.
It's not AI, it's an AI architect who does it for us.
Yes, but I mean, there should be a reason, right? And that's the question, like, what is the reason? Why
That's
the
just the
10%?
standard, that's like the gold standard in all DRUs, because you're testing it, and then, we wouldn't just do 10% and then head to clinical trials, we would do 10% and then do more research into it, and, you would train it not just on 10%, we just wanna see the 10% of the algorithms working correctly, and then you would go into huge patient populations.
So I guess the question is, because this is the first time to do this kind of deal, is the 10% actually valid for that? Because all the time, like, we get models, right? And models don't always work for every situation. So I think that's the question, like, you're gonna have to look, will that actually validate for real, right?
Well, we
In
have
this
10%
situation.
validation and 10% testing, and then you would do more. So this is a stepping stone because no one's ever really done this before. They've done it for heart attack and stroke and other things, and that's very important because heart disease is the number one cause of death in America. But I do think that sickle cell is not even getting 1% of the funding, and there's so many people who have it. I think it's really important to utilize what we have.
All right. So this is the end of the session for the morning. We're gonna we would invite you to go to Buenavida, I think, for our panel discussion, yes, at the same time today. There's also the math, I think, is also going on in this room, so we need to evaporate as soon as we can. But please come back for the next session at 12.